Right, thank you so much for joining us today. I imagine some of the people here will already know Charlie and the amazing work that he does right across Scotland in relation to stroke work. Um, Obviously, Charlie, you come from an occupational therapist background originally, don't you?
Yeah.
And then have sort of used your expertise within that area to specialise in stroke. So it's really, really exciting to have you here today. Um, I'm Zoe Strong, Account Director at Prego Digital Healthcare, and we've been working very closely with Charlie and his team at NHS Lothian and also Chest, Heart and Stroke Scotland in the work that we've been doing around our Life After Stroke pilot due to launch this December, everyone. So this is a great opportunity for us to sort of talk about that. I will be asking Charlie a range of questions, but do not fear, there will be time at the end to answer your questions. So if you've got questions during this, please jot them down, and then we've sort of made sure we've got plenty of time at the end so that people will get a chance to ask Charlie questions. So if we crack on then. So first of all, Charlie, um, could you tell us a little bit about your background and what your current role involves?
Sure. Well, first of all, it's just lovely to be here and thank you for the opportunity for this. It's a bit different in that it's not the usual presentations that I do, but it's your question and answer session. So, yeah, so also, I suppose, I should say that I currently the Allied Health Professions stroke strategic lead for Lothian, and I took up this post in June of 2022. So I've not been in it for very long, but it was really great timing because of the launch of the progressive stroke pathway in Scotland. And then, of course, just a few months ago, the National Clinical Guideline for Stroke. So a lot of the role involves working with our managed clinical network team in terms and all the teams across Lothian in addressing the priorities under the progressive stroke pathway. So that's it from a kind of strategic level. And I have to say that the teams have been wonderful, and also connecting up with the rest of the country through the Scottish Stroke HP Forum. We were just chatting about the conferences people were joining the session there that took place 2 weeks ago, which very successful nurses and allied health professions conference. And also very recently, I've become part of the Royal College of Occupational Therapists stroke forum, again, specialist section stroke forum, and just stepping into temporarily into the chair role to help out a little bit. So UK wide as well. The other part of my work as consultant occupational therapist, and this is the bit I love, is that I continue to have a clinical remit as well. So it's not just all about projects and developments, it's about the delivery of services. And my background in the many years I've worked up till now has really been as a clinician all the way through a number of years in management, but I was still seeing patients in clinic over the periods. And the experience I've had certainly over the last 20 years has been in stroke, and lucky enough to be at the outset when stroke units were in their creation and being developed under the recognition that stroke units were saving lives significantly. So very much involved in that in working Fife over the last 20 years, creation of the new stroke unit, working in acute stroke, rehabilitation, and also in the community as well, in partnership with community teams and the Chest, Heart and Stroke Scotland wonderful nurse liaison service. So it's been fantastic to have had the opportunity to work with people right through the whole pathway, and it certainly informs a lot of the work that I do now. I should probably say as well, for NHS Lothian in this session, the views that I express may not necessarily represent the views of NHS Lothian. I'm just saying that, just not that I'm going to say anything controversial, but just to get that out there just now.
No, but that's brilliant, Charlie. And I think what's been so helpful about having you involved in the pilot is the fact that you have that bigger picture view, but you're also working directly with patients still. And I think the fact that you do still work frontline is really, really helpful. And we just massively value that. So as someone who is currently involved in our Life After Stroke pathway, can you explain the benefits of a digital health tool in supporting people who have had a stroke?
Yes, certainly. Probably it's worth mentioning for everybody on here. I'll say a little bit about the project that we're doing, but also I'll say a little bits about digital health and rehabilitation in general as well, because hopefully that will be of big interest. Certainly it's of big interest to me in the develops. And I have to say, I'm no expert in this, just involved in various things regarding technologies. So for people's awareness, some of you, kind of are aware of this digital pathway that's been created. It's about information provision to stroke survivors at sort of various stages of where they're at in their recovery, and it's regarded as very important because certainly from our lived experience group, which was recently formed in Lothian, one of the key things that they've mentioned has been their experience of that lack of information coming to them. Now, it could be lack of information because it wasn't given, or it could be lack of information because, admittedly, they may have not remembered the information that was perhaps given verbally at an early stage, and they've not been able to retain that information, and nothing to put their hands on any hard copies of anything. So what the digital pathway involves is joining up with the already existing tailored talks system, where these are a series of slides of information relating to the different aspects of stroke that people might be experiencing. And the project that we've been currently working on, the Life After Stroke digital pathway, is an additional mechanism where people who have an email address and have digital access can come onto the system. They answer questions from a questionnaire, and that questionnaire will trigger off the specific talks, the specific slides that then come onto the person's system for them to hold on to. And if you've not seen the tailored talk system before, I regard it as an important complement to the information that's out there already. And some of the information out there already includes the, fantastic resources, booklets, fact sheets from Stroke Association, from Chest, Heart and Stroke Scotland, from different strokes, a Headway, all the different various organisations that produce materials. But what this presents is a intermediate step so that the person can receive information that's based on their experiences of stroke. And as we all know, stroke has very diverse and very varied consequences. So, and again, this is something that has been mentioned in our lived experience group. Sometimes the information is too much because it includes things that are relevant to the person, but also things that are not relevant to the person. So this mechanism allows things that are particularly relevant at that time. So the project, we're getting ready for a test, in a site, in the coming, so by about December, we'll be ready. And at the moment, very busy piloting the questionnaire, making sure things are acceptable for people. And then we'll test it probably in a unit to start with. Going to test it actually, although when we look at the system, we think actually this is suitable for community settings. A decision was made to actually test it in an inpatient setting, acute stroke unit, because two reasons for this. One, it's where teams feel the need to provide information anyway at the outset. And the other reason, again, from that lived experience opinion, that it's a key time where information is needed, and sometimes not the obvious information, because we think it's all about stroke, but actually things like work, is a key aspect of that time, because one of the people in our group, said that the first thing he thought about was, how am I going to continue to make money and live and support my family? So these things, aren't for further down the line. These are immediate thoughts that people have after they've had their stroke. So what that does then is it allows information to be provided to complement information that's already there, accessible information as well, because these slides can be done in various formats. And I'm working on cognition slides at the moment, which, sort of naturally can't contain too much information, have to be of a level where people can actually take in the information, even if they have limitations with attention or memory or ability to process information, etc. But the other mechanism for the digital pathway is that there is support, that can be offered from, from either telephone call, etc. For, on the basis if somebody, makes that request through the system. system. So that's the first part of it. The first big area in terms of digital health is that information provision, which we all know is key. And for those of you involved in the progressive stroke pathway, you'll know that some of the criteria to meet the priorities, for instance, is having, one of the examples is driving. People should have routine driving information at the outset. And we know that that's probably not been done. Teams are busy. You're addressing these immediate needs. So that's not an immediate thought on anybody's mind. But then we experience later on in the pathway, maybe months down, that people will say, we've not had any information on driving. Some people have started driving without actually knowing the regulation. So that's just one example of the importance of that information. The other couple of bits that we'll probably touch upon in some of the other questions in today's session are things like digital rehabilitation systems, but also remote consultation systems as well, which especially the remote consultation, which has become key in recent times, and the digital rehabilitation mechanisms, particularly with the launch of the clinical guideline for stroke, where we're now have a target of the minimum of 3 hours active movement rehabilitation and 6 hours of remaining active a day for stroke survivors.
I might stop you there, Charlie, because we're moving on to the next question. But no, that's brilliant, and that's given us so much background. I mean, it's such a huge area, isn't it? It's such a huge area. It's so complicated, and I think that's why one of the beauties about the Life After Stroke pathway is it gives people less information instead of more. And you sort of mentioned that, which is great. Next question then. So what strategies or practices can healthcare professionals share with stroke survivors to enhance their engagement with digital health tools? And you were sort of, I think, starting to touch on this, but
Yep.
I wonder if you'd be able to sort of expand on that question a bit for us.
Yeah, there's probably a couple of different thoughts to this, the strategies to enhance engagement. And probably the first thing that makes me think of is that this isn't a thing on its own. This is a means to an important end. So the use of anything digital isn't just about the digital. What is the potential advantages that it can maybe give. So for instance, thinking about, let's maybe start with the rehabilitation technology. It's not about the use of any device. For instance, many people use the grippable device at the moment, and sometimes the question will be asked, well, where's the evidence behind using it? And it's not so much, in my view, the evidence behind the evidence behind that particular device is the evidence behind strengthening interventions and the opportunity to do something of a higher intensity with the use of the device. So certainly the engagement with something like the Life After Stroke digital pathway, it's all about what that information can have an impact, how it can have an impact on people's life at whatever stage of the stroke that they're at. And if we're starting it at the start end, it's emphasizing to people to, this is intended to, provide some of the information to questions that they might have, or actually provide information to questions that they don't have. And what I mean by that is that often people don't know what they don't know. And so the provision of information based on a questionnaire can be useful in filling that in, because people had their first stroke. They've probably never heard of apraxia, or they've probably never, had the concept of various perceptual issues either. So some of that information is key in being accessed. So that's the first thing. It's actually for us to have the responsibility of engaging with people and having good conversations about, what's needed here, what's needed in this person's individual situation and life, and how can information actually support that. Other aspects of engagement in any digital technology is the removal of barriers that, of which there are kind of many. There are systems that we'll have in place which, once set up, can be used quite easily, rehabilitation systems, but often the setup of the systems is really quite involved, whether it's the various levers on a kind of SIBO arm support to the traditional E-Link biometric system, which, was great for use, but actually required, quite a time for therapists to set this up. So it's to remove these barriers and bringing it into the here and now, this day and age. Even things like having updates on a device, digital updates, can be a barrier for somebody using it. Interfaces on some of our digital tablets. I worked with somebody with the Grippable, and on one visit back to the home, they had it at home, and they had lost the actual app to get into the device, and they'd spent a week without being able to use it. And what the problem was the app was still there. It's just that the device's screen had been swiped so that the app was in a group of other apps that weren't immediately visible on that screen. So the simpler the interface, the more accessible something can be, and the fewer the stages that people need to set up and use digital technologies, can really enhance people's engagement. Another example that many of you will have faced is the use of the Near Me, the Attend Anywhere system. And when first used that during lockdown in terms of delivering clinic using that device, the instructions that many of you remember were that people had to bring up the URL and copy and paste the URL from instruction, and then paste it in, and then open it up, and then they got through to reception, and they had to ask for the specific clinic. And that was really so obstructive and challenging for people to go through that, eventually adopted a method of just being on the telephone with somebody and talking them through the system in order for them to access that. So that's probably the main thinking in terms of enhancement, but also offering the experience as well. I know that some of the technologies people, so older people particularly, would say, oh, I've never touched a computer in my life and what I'm going to do with it. Then they found out that they actually really quite enjoyed it once they had a trial session of it. So to actually offer its use and trial in the first instance.
That's really interesting, because I think it shows us that it's not just about having the right digital tool at all, is that? It's about the implementation, and it's about how that tool will fit with someone on their recovery journey.
Yeah.
And it's making sure that it's making sure all of the support is in place to make it as successful as possible, isn't it?
Yeah.
Which is really interesting. And I guess from our perspectives as a technology provider, it is just keeping it as simple as we can possibly keep it, to make it as usable as possible for people. So again, I think you've mentioned this a little bit, Charlie, but the next question is, can you talk a little bit about the importance of personalised care plans? And obviously our discussion around access to digital tools is very much about personalised care plans, isn't it, really? But personalised care plans in stroke rehabilitation, how digital health can support this approach. So I think you've touched on it a little bit, but if there's other things to add there.
Yeah, there's probably a couple of things to expand on here. And again, it's for the different purposes of digital health. I'll go back first to the Life After Stroke digital pathway. We all know that stroke can cause such an individual profile of different effects. So, some people have got movement loss, other people don't. There's various cognitive, emotional, cognitive perceptual factors. Apraxia can be in there as well. So a whole combination of things, and then bring in the person's own life, their experiences. Are they working? Are their family? What are their roles in life? What's important to them in life? So considering all that, it is a very individual experience, and information that that is provided, I guess, is useful to have it as individualized as possible. One thing that, to mention on this question is a thought from a couple of weeks ago. It was actually during the National Scottish Stroke Audit meeting back a few months ago, and then again repeated during the Nursing and HP Forum Conference from 2 weeks ago. Is a stroke survivor giving an excellent presentation, but actually talking about how it can be traumatizing to tell their story again and again. And this was clarified because it's not so much telling the story for other people's benefits. We'll have this national stroke voices, and we'll have the we'll have various people telling their story to give us access to their lived experience. But it's within the time when they're actually undergoing treatment or rehabilitation as an inpatient, perhaps, where the experience of different clinicians coming to them and asking again, oh, can you remember what happened? And from a clinician's point of view, there's often good purpose for doing that, because it's useful to hear it in somebody's own voice. You're actually maybe assessing their memory or their cognition, or you're trying to get to what matters to them. But the awareness that can be traumatizing is important, and that's where digital documentation comes into it. Certainly in, sort of moving into Lothian and from Fife, everything was being developed in terms of systems that everybody could view. So there was the opportunity to view somebody's complete documentation before actually seeing them. So to know the details there without necessarily repeating the questions of somebody else, and also appreciating the individual experience that somebody has as well. So it was just to mention the importance of documentation that is accessible to the various clinicians and teams across the pathway. It's also saying as well that information is given, the digital pathways don't replace the existing information that's given, and it also doesn't replace, but is intended to complement good conversations. I use the term good conversations. It's something that is a method, if you like, for reducing the expert model that we have, and really trying to, work in partnership with the people who use our services as well, so that we avoid too many assumptions. In the past, I've seen documentation, I've written it myself, where you see somebody who's had a stroke and immediately you jump onto the plan of movement, rehabilitation, walking rehabilitation, washing and dressing, when in fact, these might not be the pertinent things to that person, or it needs an extension. Walking for what purpose? Our movement for what purpose? Information for what purpose? And that purpose could very well be something very specific. I always have fond memories of a lady that I worked with whose goals were reflected in what she did. She was the singer of a punk band, and I remember her goal being very much the case of actually holding an SM58 microphone and being able to pass it from one hand to another. So yes, it was about movement rehabilitation, it was about strength, but it was also about, what purpose that had. And again, a very
real goal, isn't it? And when she was able to do that, and when she was able to go back to doing what she was doing before,
yeah,
like,
definitely.
the power of being able to do that is amazing, isn't it?
Yeah,
Motivation, and
definitely. Yeah, so that's probably the kind of key thoughts on that. Trying to think. Yeah, I suppose one other thing to mention, this is more on the rehabilitation front now. There's an increasing number of systems which use measurements, say, for instance, movement and strength, and are applying these to actual functions. So it means that games and activities are always achievable. And I've said this in conferences before and in workshops, that we risk when we're not delivering person-centered practice and really acknowledging what's important to the person, we do risk making assumptions, and therefore we will deliver interventions which are probably not matching the person, or we're testing them so much so that the person's experiencing repeated episodes of failure. We do this and we'll run cognitive screens, and the person's not scoring points and they're not getting the memory aspects of it. And they're not moving, they're not able to walk, they're not able to support themselves on their weaker legs. So it's day in, day out, we risk that the person's getting the failure reinforced and difficulties reinforced. So digital systems which actually measure and apply these measurements, so that somebody undertaking the subsequent games, it means the games are achievable for the person with the right level of challenge. It really comes in because I suppose maybe it doesn't happen so much now, but when Xbox Connect came out, when the Wii Fit came out, these were used sometimes very successfully, I have to say, in rehabilitation. But the limitation for many of the commercial gaming systems were that they were too fast, they weren't gradable for people who'd had a stroke, and as such were not as individualizable, if that's a word, to the person that some of the tailor-made systems can actually deliver.
That's really interesting. You wouldn't think of things like that, would you? But you're right, having something at the right level so people feel that they can achieve. And I think that's one of the things, Charlie, when we've all been working with this app, trying to look at the questions, trying to make sure the questions we're asking are achievable, so people feel empowered by doing it, and not feel demoralized, and trying to get that balance. And the challenge we have is you don't know until you test things, do you? And everyone is different, and you have to just go with what you feel will work, get a few people to feed in, test it and see. But no, I think those things are so important. So the next question then, and again, you've talked about this a bit, what are some of the common challenges that stroke survivors face in their rehabilitation, and how can digital tools support them? We've talked about that, haven't we? Because we've talked about using computer games, how they could be supported there. Are there other things that you've got that you could add to that answer or that question?
Yeah, probably an important thing to bring in here is that, again, this is something we're all aware of. I'm aware when I'm saying these things that I'm looking at the names of people that are recognised on the call today and thinking, wow, you could probably talk about this more than me. But it's the recognition that many, if not most people, don't just have a weakness after a stroke, or don't just have a cognition issue after a stroke. There's a whole combination of effects for stroke, which means that one of the challenges is for instance, a system that's a physical rehabilitation system, but actually being geared towards somebody who has difficulty with sustaining attention, for instance. And it is a difficult thing because people will face greater or lesser levels of challenge with this. The across the country, in Scotland anyway, the various pathways for, say, upper limb rehabilitation have been formed, and different boards have got examples of this. And one aspect that we've added to in Lothian is the actual cognitive considerations for upper limb rehabilitation. So ways in which upper limb rehabilitation can be delivered but being mindful of the compensations or adaptations that might be needed for somebody with reduced attention, for instance. So you might choose to do sessions when you recognise this, not in a big busy gym area, and not to have music playing in the background, but actually, have the person actually working on systems that are actually in a quiet area. And so similarly with digital technology systems, it's sort of necessary to have these geared towards the same, where a movement system is not just for somebody with pure movement changes after the stroke, but to actually broaden it out and address the needs of people who have got cognitive and perceptual effects as well. One of the very simplest comments that I've gone back to some of the providers of digital technologies is that, be aware of many people who have reduced figure ground discrimination. And when a game on a screen is too busy, for instance, or if the colours are not contrasting enough, that can actually be very challenging for somebody to play that game or undertake that particular activity.
So it really is about looking at everyone as an individual, isn't it? And and making sure that the physical and the cognitive challenges are sort of put together when you're looking at how you support people. And I think that's why, as you were saying, Charlie, having people from so many different disciplines at the Scottish Stroke Conference was so good. I imagine one of the massive benefits from that is that, how we train people in this country, you'll be trained as a physio or an occupational therapist or a psychologist. People are focusing on different areas, aren't they? But actually, all of those do need to come together for one individual who's had a stroke.
Yeah. And we'll learn so much from people's experiences, I think, as well. I mean, after all these years in stroke, I still love to pick up on what people are saying. At one recent event, back in June, we had the National Person-Centred Care. a person-centered practice workshop in the middle of June, and we had gentleman Tom Middlemiss, and many people will know Tom because he was in the film When the Words Away Went. If you've not seen it yet, still on Channel 4 player, there's an excellent documentary account of 3 stroke survivors who have lost their communication ability and the challenges that they're heading towards. And Tom, when at his time a few years ago at Edinburgh Community Stroke Service, there was a trial session of art therapy there, and that triggered off his interest in expressing his thoughts and feelings through art. And so much so in that film, it's all about him putting his art exhibition on and presenting his art exhibition. But he very kindly presented, did a recording of him for that national workshop. And one of the things he said was that through time being an inpatient, he discovered that he was very noise sensitive, but the team in the ward, particularly nighttime, were just all very shouty. And it's right enough, when we're in the ward, we all do it, because we're trying to make ourselves heard in a very clear way. And of course, it can come across as very shouty, or else we're talking to people across a room and it's noisy. And the noise that's involved in aspects of that is key. So it's actually kind of learning, so many of these individual aspects as we go along. And it really emphasizes the importance of continuing to listen to the voice of lived experience.
Yeah, no, that makes an awful lot of sense. So on that sort of lived experience theme, our next question is, because obviously when someone has a stroke, it's not just about them, is it? It's about their family, their caregivers. So how can digital tools be used to support the family? How can they be used to support caregivers of people who've had a stroke? What opportunities can you see, Charlie, for us to provide greater support to, I guess, the wider network around individuals?
Sure. Thanks, Zoe, again for that. I think this is a great question because, it's not just about the stroke survivor. It affects everybody, family, friends, everybody around them. I suppose starting off with the digital pathway, life after stroke, digital pathway and its information provision. Its starting point will be around the stroke survivor themselves, but it's well recognised that information is very important for the families as well, because if it's a first stroke, this is often very new and very distressing to them. So understanding aspects of stroke is key. Plus, it provides an opportunity for stroke survivor to discuss and talk with family members as well. And as we probably all know as well, that having information about something gives us a feeling of control. And particularly in a time when somebody's just had a stroke where they feel such a lack of control at that stage. So I think as we move on with that development, looking at methods in which information can come to family members is going to be key as well. Taylor Talks allows that anyway, because the pathway is all about getting that individual profile of information to the person, but certainly any, of us as clinicians who are signed up to the Taylor Talks, have an account, have the ability to actually bring that information off and provide it to people. Other opportunities, again, continuing on the individualism type approach, remote clinic working, not just for the pandemic, but benefits of that. Apologies, because I still need to get the references for that, but at the OPSIRIS conference that some of you may have been at, that's the Organisation for Psychological Research into Stroke, and UK Stroke Forum 2020, there were 2 presentations of research there. I think they both may have been from Australia and New Zealand, and they found that cognitive assessment done remotely actually was found to be as valid as it being done in person. So, I think that was a good finding, because we've often thought, as a poor relative.
What is the reasoning behind that? Is that because people feel more comfortable in their own home, so they're more relaxed? So that sort of counterbalances for the fact that you're not picking up all the other visual cues that you would get someone, or
Potentially, and I think that's probably reinforced, Zoe, in the other piece of research which showed that memory rehabilitation actually worked better remotely than in person. And, you know, I can think of that directly because the cognition clinic that I used to do in many of the sessions were the letter of clinic invite for them to come into an acute hospital to, you know, first of all, leave their house, travel, try and get parked somewhere at a very busy period, make their way in quite a distance into the clinic room, find the clinic room, one of many, you know, one of about 5 different clinic areas, and then come in. And so the level of stress must have been, you know, quite great at that time. So it probably supports that conclusion that actually remote ways of working when the person's comfortable, safe and secure in their own house, and even free of the feelings that, oh, their house needs to be tidy for somebody coming to visit them at home. So there's maybe that aspect as well. In terms of the assessment side of things, I mean, that probably comes into it, but probably the tools that are used, and maybe shows that the tools that are used are robust in online delivery as well as face-to-face delivery as well. So it's maybe a credit to some of the tools that have been used. And I know that I was using Oxford Cognitive Screen remotely many times, which involved a bit of a hybrid approach where I would be mailing hard copies of paperwork through somebody's door during the pandemic, and or mailing them out to people in preparation for the session that would then take place on screen. But that was where another part of where the question about the relatives and family members come in, is that I really had a positive experience during the whole near me period during the pandemic for involvement with people's patients and relatives, because of most of the people that I worked with were older people. You know, most of them would be in their 80s that were coming to clinic. They needed support to be set up on that system. And as a result, very often with the permission of the person I was working with, their family members became part of the session as well. And that had huge benefits, both from an assessment perspective. You know, I smile when I used to think of this done in person, because, and it still does get done in person, but when you're talking to somebody who maybe lacks insight or maybe a bit guarded, then you're looking for the relative reaction, often sitting behind them strategically. So when the person's telling you that, yeah, they're able to do all these things, they don't have any problem, and you're watching the son or daughter, you know, sitting a few feet behind them, just shaking their head and giving you the message that that's not actually the case. The whole kind of near me remote system with family and relatives actually, you know, gave the opportunity for these conversations to happen more openly, rather than somebody gesturing frantically behind the relative who'd had the stroke.
It's interesting, isn't it? And I think part of it is a cultural challenge in the UK, because no one wants to say they can't cope, do they?
Yeah, yeah,
Everyone's
definitely.
quite proud and everyone's quite stoic, which is very good for many, many things, but not very good when you're assessing what support people need.
Yeah, yeah. It was actually something that relates to, I mean, this is getting away from the technologies in our pathway, but
Yeah.
it's an observation that I had using the outcomes in these clinics, that often people would score themselves higher when the first rating. So, for instance, one tool is the EQ5D, and there's a
Mhm.
rating thermometer in that where people will rate their general health today. You know, how out of 100, how good is your health? We're hundreds. Best health you can imagine, zero is the worst health you can imagine. And, you know, somebody might mark themselves as 60%. And then a few weeks on, either in an interim measurement or, you know, at the end of their time, they might rate themselves lower, but actually verbally reporting, actually I feel, you know, quite a bit better, yet they've gone to 40% for their health. And that was an indication where, you know, first meetings, they maybe didn't trust me fully. They didn't know what the outcome or what the consequences of their engagement with this particular clinic or intervention was going to be. So they actually gave quite a guarded score to start with. Then, if we were to take the figures by themselves, it looked like they got worse. And by then, maybe they did with my intervention, who knows? But I like to think that the first score was actually not a true reflection of the score, as people will admit, you know, once the therapeutic relationship, you know, has built up in a stronger way. So I suppose we're going into national developments about the stroke audit in Scotland, and so, you know, these things in terms of these types of ratings, you know, will be considered during these developments as well.
It's really interesting. It's really, really interesting. Right, we've got one more question, Charlie, and then we better open the floor to questions, because I'm sure everyone's listening has got loads of questions for you. we've touched on this a little bit, but what are the main challenges of implementing digital technologies into current rehabilitation practice? And I guess part of this answer we'll know so much more of once we've implemented our pathway, won't we? Because
Yeah,
we'll test it and we'll think we know what they are, and then we'll find out more from testing it, I imagine. But
sure.
off the top of your head, what things can you think of as the main challenges that we'll
Um,
face?
Two main challenges. First of all, the cost challenge. Some of the
Yeah.
systems cost an awful lot of money to implement and involve. Like our project has done so many hours of people's input into, into the development to make sure it's right. One thing I would say, briefly about cost, is that in rehabilitation, particularly, and in sort of a non kind of investigative type of era, we think about, we think £1,000 is a lot of money. But when we think about what medical equipment costs and what a bladder scanner might cost, etc., these prices for something that's essential in people's rehabilitation and recovery after a stroke is actually small amounts compared to what you might spend on an MRI scanner, for instance, into millions of pounds. So, but the other part of it is the time it takes to get through data security systems, data security. Information technology security is essential, and we know that. But actually, clinicians who are working and very busy at the coalface do not have the time to undertake these processes. So I think there's so many opportunities without somebody taking this forward and having the time and remit to take it forward. It just won't happen because nobody can get past these barriers.
I think that's a challenge, and I think that's something that technology companies face across the whole of the UK when it comes to healthcare. We were always asked, why is it that health technology development, why are our products so much slower to market than fintech? We have all of these additional barriers, and it's going into a system that's already very stretched, isn't it?
Yeah.
And being sympathetic to that, and working with that, but still so much potential,
Yeah.
makes such a big difference.
Yeah, and having national processes as well, maybe standardized so that if somebody's done it somewhere, then that can be shared, with another board, which we've tried to do in, a couple of recent situations. But the boards are so different from each other; they just operate their own way and want things done completely again. So a government steer on that would be very useful.
Yes, no, I agree. I would definitely be in favour of that as well. Brilliant. Right. Thank you so much, Charlie. Those are my questions. And I imagine lots of people in this audience have got questions as well. If you'd like to raise your hand, or if you'd like to put a question in the chat, then we have 15 minutes left to answer some questions. So I don't know if anyone's got questions for Charlie. You've covered so much, Charlie, to be honest. I found that really interesting. Let me just see if there's any in the chat. Hold on.
Yeah, and
Uh,
again, a lot of that was my opinion, and so feel free to disagree with anything that said. It's always good to have discussion and debate, and I'm always learning about stuff.
yeah, I know, and it's brilliant, isn't it? It's brilliant to have that sort of. You've got to have that learning attitude, right? Has anyone got any questions? I'll see if anyone's raised a hand. If not, I might ask a question. I guess my question to you, Charlie, would be: where do you see technology going in stroke care? What do you think the future will look like if we went on a time machine 10 years from now, because we know it's going to be a little bit slow maybe in health?
Yeah.
What sort of technology support would you like to see for people?
Yeah, the ongoing information provision, but all and rehabilitation provision, which is like a big toolkit of availability for people, sort of in boards right across the country, from inpatient units right through to community and community hubs. Yeah, that's certainly what I would like to see. We know that any one system can't do it all for everybody, so we just need a range of different robust tested things for people to be able to access for both information and rehabilitation.
No, that sounds brilliant. Right, we've got a hand up. Is that Sean, have you got a question? Would you like to unmute yourself and ask your question?
Yeah, that's fine. Can you hear me okay?
Oh, it's Sean. Hi, Sean.
Hi, Charlie. You right? I suppose just a couple of points. One, I suppose one of the things about system, isn't it? That I kind of only found out recently, sitting in some of these meetings, is about procurement, isn't it? And the
Yeah.
open to litigation if you don't do tender or whatever. But I think we're okay with stuff like this because we're developing it, or is there something that maybe even um, yeah, I think it's something along those lines that it's not so bad. But if for example, I think well, Brionomics is the perfect example, isn't it? Because that's where it's the meeting that was in where they were talking about evaluating artificial intelligence, and yeah, you just need to other companies, I suppose, could in theory sue, couldn't they, if we didn't tender things properly.
Yeah, that's it. It's such a good point, Sean, and I think we are getting better at it. And probably what we can use for the uninitiated are, even workshops on that type of thing. I don't know if they're available, for completing a data protection, assessment form or a system security form, because it is necessary, for safeguarding, make sure it's done the right way. And also, with that awareness, it means we don't go blind into the situation where, as I've experienced, we've got the money, can't spend the money because these things haven't been done. Therefore, procurement cannot act and order things because it's not had its proper checks and systems done. So yeah, so there's probably things we can do with awareness, and also people on digital leadership courses and these types of wonderful things. The people can explore these as projects. It would be a great contribution. Yeah, that is a great comment, Sean.
And the other one, which is probably a bit more difficult to answer, is I suppose one of the um, well, I think I know the answer to this, but anyway, I'd be interested in your thoughts. That do you know sometimes we don't have all the answers, and obviously your first response is going to be it's about being honest. We don't have all the answers, but is that a problem with the app in any way, kind of communicating that, or is it, is it something that somebody could then hold up later and go, well, look, I've got hard physical evidence that you said X, Y, or Z, or I'm just trying to think of potential pitfalls with the system.
Yeah. That's an interesting question as well. Yeah, do you get held to account for
Exactly.
information that you've given or information that you've not given if there's any blanks? Now I don't know this for certain. It's just I suppose it's just an opinion based on processes that I'm currently going through at the moment, where one system is in the hands of our IT department, and so rather than doing an assessment on the basis of information I've given, they're actually weighing up all the information and doing a risk assessment on the basis of that. So it's not a kind of black or white type of situation. It'll be a case of, stating, what certain risks are and are the risks manageable, which may be a more, a kind of more considered way of doing it, let's say.
Yeah, I mean, I think it's again, as long as you're honest and say you don't know the answer, then
Yeah.
I think you're less likely to get into problem. Obviously,
Yeah.
every patient or family member is different. Some of them might not be happy with that, but what can you
Mhm.
do?
Yeah.
It's definitely the best strategy. But I think probably there is a certain safety in the fact that a lot of these slides referencing Taylor Talks here more than the Life After Stroke app, but the Taylor Talks side of things, where it's people that are making the slides are obviously largely going to be experts in the field and will reference the slides properly. So actually using Taylor Talks give you that a bit of a security blanket there of knowing that you're given the best evidence that you can or the best answer that you can.
Yeah. Yeah. And actually, that leads us on to a very necessary stage as well about the testing of things, because, what can be clear to us, even on a very simple slide of information, how at risk is that of interpretation in other ways. And so these are the types of testing that needs to be done before things are in final version.
Yeah,
Yeah.
I think you're absolutely right. And that is the value of doing a pilot, isn't it? I know I say this quite a lot, but I think it's okay, as you say, Sean, to not know it all and to be like, we know this, let's test it, let's see what happens. And then we'll learn from that and we'll know more, and we still won't know everything. And I think with from our perspective in technology, you will never have a perfect technology product. It's something, it is always developing, but it's having something that's good enough to have really positive impact, isn't that?
Yeah. Mm-hmm. And probably just to add to that, I know that, what we'll be doing, addressing is the balance between, is the system worthwhile against the time it takes to actually deliver the system. So, I know that our clinicians, sort of for it to be successful, have to feel that actually the time that they're putting into this is worthwhile from the patient's perspective, but also from their time perspective too.
Yes, it's exactly that. And I'm hoping clinician time will be very minimum with this, but we'll find out.
Yeah.
Yeah, I mean, just to come in on that point, we've had access to their talks for a few years now, and I have used it a wee bit, but it is the odd time that I've used it in clinic, and you've maybe had to try and figure out the slides and remove ones that aren't necessary and put it together for that person so it is tailored, and then walk down to the printer and get it. It just adds a lot of time when, and everywhere is set up differently, but if you're seeing the hot clinic when you're on call for thrombolysis thrombectomy and you don't maybe have that time, so time is a big factor, particularly as a clinician. I don't know if probably everybody else in the call could answer, you as well, Charlie. Just is there a bit more time maybe as a therapist, or is there more time in different settings as a therapist to deliver that? Because it always seems everybody's stretched everywhere as far as I can see, but
Yeah.
most of my experience is from the acute.
Yeah, and it's probably where I saw the possibility, because when I came into the project, it already started, so I just kind of came into it. But from my experiences of putting information, like you've just said, Sean, for people in an individualized way, I thought actually this could be a time saver for me if I was doing it, because the number of different PowerPoint slides I put together as information for people, whereas if we've actually constructed the information and it digitally automatically gives it to the person based on questions, then there is a possibility, a useful addition to the range of tools that we already have.
I mean, it could be done by well-trained band fours that weren't even necessarily a physio or OT trained. The way that a lot of the wards now have people that would have been old term, sorry if I offend anybody, but the nursing auxiliary role, band 3, and a lot of them are band 4s now. So band 4s could probably be trained that necessarily weren't physio or OT. Band 4s could be trained to do it, I would have thought.
Yep.
So I think there is potential to get it into the right, you're right, it's about having the right clinician, isn't it, for that side of the tailored taught system. And then hopefully with the life after stroke pathway, our reasoning behind this is it's patient-led. So it should only take a couple of minutes clinician time. And then after that, it should be purely led by patients. And hopefully we will find that that really does free up clinician time. But you're absolutely right. For more complex information, having that coming directly from a clinician is really, really helpful. Has anyone else got questions? I'm conscious we've got a few minutes left, so I'm sure we'll have other opportunities to speak to Charlie, but this is a good one to speak to Charlie. Mark, your hand is physically up. Brilliant. And would you like to ask a question?
Old school. It's actually maybe more for yourself, Zoe. I'm from Northern Ireland, chest, heart, and stroke.
Oh, brilliant.
And yeah, and obviously Ursula's briefed me on on a little bit about the possibility of the project going forward. And I suppose the thing I must admit that I'm worried about in terms of our project is the amount of time that it will take the GP or someone from primary care to refer somebody in, or the process of the GP referring their patient into the tailored talk systems and that process and what they'll have to do. And again, it just goes to whether the time it takes them to do it is worth the actual information coming out of the system.
Yeah, no, definitely, Mark. And I think the pathway that you're referring to is the work that we've done with long COVID and COPD. So this pathway, and we've maybe not explained this one is people would be onboarded within a stroke unit. So this one doesn't go through GPs. What we've done with our long COVID pathway in Scotland is that we've integrated within Sky Gateway, which is the system used by GPs for referrals. And so the time it takes them to refer onto our pathway is no longer than any other referral. It's exactly the same system. So just as a GP would refer for physio or might refer to a neurologist, they use the same system to refer onto the digital pathway. And
That's
the only
perfect.
additional time for GPs is for them to just have awareness of the pathway. And so we've done quite a bit of work across Scotland to make sure that they understand what the pathway is and what the benefits are, so they see the value in making that referral. And we have posters up in sort of staff rooms and toilets and stuff so GPs can see that. And I imagine we'll probably end up doing something in stroke units as well, so that people feel empowered to refer onto the pathway. But I think from our perspective, we're very keen, and this is why with this project we've worked with clinicians from day one to really look at the pathway to try and make it as easy as possible, because we know how stretched everyone is. And the reason for doing the Life After Stroke app was exactly the reason that Sean was talking about. You know, clinicians know the value of tailored information. They all want to give it, but they're very stretched time-wise and actually don't have the capacity to do extra. So if we can make it as streamlined as possible, then it's far more likely to actually happen and then to have benefit.
No, that's really good, because I was just wondering, oh my God.
Does that help?
Well, yeah, well, they have to jump out of systems and go into something else and do something else. And I was thinking, oh God, that would be a hard sell. So thank you. Thank you, Zoe.
We try and make it as easy as possible. What we've done in Scotland is for our long COVID pathway, we worked with a couple of GPs from day one, and we actually had them on the working group. So when they looked panicked, they spoke to us, and we tried to make them not look panicked, if that makes sense. And this is why we've had such a multidisciplinary team involved in this Life After Stroke pilot, because, and we know we won't get it all right. We know we'll pilot stuff and there'll be something on the form that maybe won't work, or there'll be, you know, and we'll learn that over time. But by trying to involve lots of different individuals with different areas of expertise early on, we're hoping to sort of iron that out as quickly as possible.
Thank you. Thank you, Zoe.
No worries. And nice to meet you, Mark, as well. Have we got any other questions?
See, there's some comments in chat there, Zoe.
Oh, let's see if we've got any comments in chat.
Yeah, people leaving, Queen Elizabeth team, lovely to see them. Yeah, so from Katrina, there's a comment there.
Yeah, there is an example of PPP on Pogo of how streamlined you can be using tailored talks, and chest, heart and stroke health information brochure as well. So just sort of how we're sharing the information there. Ross just had a thought about people living in remote rural communities where internet connectivity is either non-existent or very patchy. Are there any thoughts on accessing this? One of the things we've done, Ross, in designing our product is that we've tried to design it so that it uses minimal amounts of data. And that's quite helpful, because that means the cost of using it is relatively low for people. So if they've got patchy internet or connectivity, they don't need it to be as good to be able to get the information. So that is something. But equally, you know, you do need Wi-Fi for it. So if there is no Wi-Fi, unfortunately, at the moment, it can't work. And what we're really hoping is that in the future, I know part of the digital strategy in Scotland, and I think in England as well, is to try and get to those areas where there's poor connectivity. And hopefully that will be more of a national strategy that will really support our products as well. So hopefully that answers your question. Katrina, I probably read your question out wrong. Would you like to?
Yeah, what I was meaning there, Zoe, was that basically we've done an example of a PowerPoint presentation on Pogo site. It's just a very short one. It's just a made-up patient that's got a few different issues that the chest, heart and stroke nurse is going out to visit for the first time. And I've just sort of tried to sort of give an example of the pertinent information that you want to give this person that's got a couple of things going on with them versus the information that you would have to give them if you were gathering it from the health information brochures. So it's like less than half of the amount of information that you have to give them by tailoring the talk to just what they actually need, as opposed to giving them, and I'm coming at this from a chest, heart and stroke point of view, with the health information brochures, you'd have to give them, say, 3 or 4 different brochures and then probably circle the different bits that they need to get access, you know, that's relevant to them. But that might be 14 pages in. So that's the other advantage of it. You know, you can really sort of just streamline it, get to the nub of the information that's really pertinent to them. Because not that I'm dissing our health information, because we do absolutely fantastic health information brochures at the charity. But at the same time, if you start reading them and it's about 10 pages before it gets to anything that's really relevant to you, how far on are you going to read then? So that's the really good thing about Taylor Talks. And the other good thing about Taylor Talks is that if you need to update it, you update it there and then, and you don't have the recycling that you have with other forms of information.
That's a good point. Yeah.
Yeah, that's brilliant. Thank you so much,
Thanks,
Katrina.
Katrina. Zoe, I was just going to add a little bit to Roz's question as well. There's some systems, Grippable as an example, on a recent update, they now have an upload system. So it doesn't, it's Wi-Fi still needed, but where it's patchy, it uploads, so it's still functional when the Wi-Fi cuts out. And so then it will kind of upload and have all the information exchange once it gets into a stronger Wi-Fi area again. So I think more and more systems will start using that method.
Yeah, I think you're absolutely right, Charlie. And it's making sure that we're following those trends and incorporating them in product design as that, and trying to sort of have that front of mind.